You're welcome to the class. So today, as we continue on our common renal pathology series on ultrasound, we'll continue this journey with simple renal cortical cysts. And simple renal cortical cysts, these are congenital true cysts that have serous epithelial lining and are fluid-filled benign cystic cortical masses. Commonly, they are seen after middle age. 1/2 of adults that are older than 50 years have simple renal cysts. They are commonly unilocular, solitary, or multiple, maybe unilateral or bilateral. They range in size from a few millimeter to several centimeter. They are of no major clinical significance. Some authors feel that they are benign degenerative manifestation of renal aging. Well, depends on the author you listen to. But on ultrasound, they are typically rounded or spherical anechoic, well-defined thin wall cystic mass with posterior acoustic enhancement, like you'll see in this image. Now, there is also the atypical renal cortical cyst, which is that does not meet the criteria of a simple cyst in strict sense. They are simple cysts complicated by thick walls and may show thin septations, and sometimes they may have low-level internal echoes that are associated with either hemorrhage or infection. The internal echoes may be diffuse or show dependent layering. The cyst wall may also be calcified. These are considered benign findings if all other ultrasound criteria for simple cysts are met. Right. Differential diagnosis besides hemorrhagic or infective cyst or abscess, thick wall cyst lesion may be cystic renal tumor and may require further investigation. Let's take a quick look at autosomal polycystic kidney disease. Autosomal recessive polycystic kidney disease, or infantile polycystic kidney disease, or juvenile polycystic kidney disease, all are one and the same thing. The abbreviation will be ARPKD, IPKD, whichever one. But again, you just put it in perspective so that regardless of whose reports you are seeing and they make any of these impressions, you know exactly what they're talking about. So this is a rare inherited disorder, and it occurs in in one in 6,000 to 1 in 14,000 live births. It is divided into 4 types: the perinatal, neonatal, infantile, and juvenile, depending on the patient's age of onset of clinical manifestation. It is characterized by a spectrum of bilaterally enlarged kidneys, nephromegaly, microscopic cystic dilatation of the renal collecting tubules or echogenic solid kidney, pulmonary hypoplasia, and or periportal hepatic fibrosis. Occasionally, microscopic cystic dilatation may be noted in this condition. Younger patients present with palpable enlarged kidney and or with renal insufficiency or respiratory failure. Hepatic fibrosis occur in older children. Early causes of death are from renal failure or respiratory failure that is associated with pulmonary hypoplasia. Most patients who survived early childhood eventually develop hepatic fibrosis and portal hypertension. Only rarely few adult survivors with this condition can be seen. It's very rare to find an adult, but when you do, it's an interesting case. In ultrasound, in a perinatal scan, bilateral massive enlarged kidneys with highly echogenic solid, bilateral massively enlarged kidneys with highly echogenic solid-looking parenchyma due to multiple microcystic interfaces will be obvious. The kidney demonstrate loss of corticomedullary differentiation. In addition, you'll find hypoplastic lungs and oligohydramnios are common in these cases. In infants, bilaterally enlarged solid echogenic kidneys with loss of corticomedullary differentiation is the main feature, along with renal dominant hypertension. Occasionally, there are small macroscopic cysts that can be seen about 2 to 3 mm in diameter. While in older children, in addition to renal failure, periportal hepatic fibrosis and portal hypertension are common. And this is what it looks like on ultrasound. Now, autosomal dominant polycystic kidney disease or adult polycystic kidney disease, APKD or ADPRD, depending on the abbreviation you choose, is the most common autosomal dominant hereditary renal disorder with no gender predilection. Incidence will range from 1 in 500 to 1 in 1,000. Up to 50% have no family history. The disease remains latent and manifests itself in the third, fourth, and fifth decade. In other words, in the 30s, 40s, and 50s. In their 30s or thereafter, the patient will develop numerous cystic lesions in both enlarged kidneys. It progressively and slowly, eventually distorting the normal renal architecture with loss of cortical medullary differentiation. Infection, hemorrhage, stone formation, cyst rupture, and renal failure are common complications that are observable, and is associated with anomalies which include liver cysts, pancreatic cysts, splenic cysts. You have cerebral berry aneurysm may occur in 10% of patients with risk of subarachnoid hemorrhage. Cysts in thyroid, cysts in ovary, endometrium, seminal vesicle, the lungs, and breast are less common. The signs and symptoms. Patient presents with hypertension, palpable mass that is due to large kidney, flank pain, hematuria, UTI, or renal failure in about 50% of the case. Ultrasound features. In the early stages, both kidneys appear enlarged and contain more cysts than expected for patients of that age, usually from the 30 years, unlike simple cysts after their 50 years. The cysts involve both cortex and medulla. In the later stage, the kidneys are huge. The kidneys are huge, sometimes reaching like 20 centimeters in bipolar length, and shows numerous ragged-looking cysts of various sizes and shapes, distorting the normal renal architecture with little residual cortical medullary differentiation are lost in this case. The cyst may be complicated with infection or hemorrhage and can contain debris or focal wall calcification. Renal stones are common in this case.